I'm going to cover the landscape today. And what I mean by that is, you know, God loved Larry. I follow him a lot. Ad nauseum, isn't it? Right? He's a wonderful man. 1/4 inch wide and 8 miles deep. I mean, he knows more about that than you want to forget. Okay? So my suggestion to you is you really get in a problem and I'm trying to deal with you, right? Call him up and say, here's what the situation is. What do I do with Dan? What am I going to do with him? That's the answer. But I want you to start thinking about productivity. You've got to stay in business. And the thing that I think is very inappropriate about the ACA is that it has misfocused our attention. You know, we're talking about providing insurance or sickness coverage. Excuse me, I want somebody well and working. I've been in this business. I'm a fellow in the college. I run hospitals way, way, way back. I've been around 40 years, darn near as long as you.
Almost.
Darn near. So, but the reality is that when we start talking about absenteeism, you need to think about your costs, and it just isn't the cost of Dave being gone. Now I got to find somebody to do Dave's job, right? So you get hunkered down with my work today, and that means your work isn't done very well or isn't done. And somebody, clown in HR, has got to come and track it. How long did you spend on Dave's work? Okay? Or I got to go find somebody to fill in for Dave. Now I got to train him, right? I don't even like that person. Now I got to train him, put up with him. And so we're not doing that, and there's a whole lot of costs. The bottom line is 9 to 10% of your payroll costs are what I just described. And that's not the profits you lost or the production you lost. That's purely on your payroll side. So I'm going to start talking about individual responsibility and how to get around that. And how, in fact, we're going to have contracts with you relative to your performance. Not job performance, health performance. All right? That's why Bill says it's time for me to retire. Okay? He's a little worried about that stuff. And the one thing that, the most significant thing about the ACA, maybe you like to call it Obamacare, right? Is the essential benefits. Now, I started HFN 30 years ago. We created CIGNA Health Plan of Illinois. They taught me the business. It's all about positive arbitrage of cash. It's got nothing to do with insurance. Sorry. All right? It's called positive arbitrage of cash. So the reality is, if you think about the essential benefits, as much as this may come as a surprise to you, all right? If I'm buying insurance, have to have pediatric coverage, and I don't need it. Believe it or not, our kids are gone. I know, looking at me, it's hard to believe. But the reality is I don't have any young kids at home anymore. I have grandchildren that are taller than me. That's, you know, and that's getting because I'm shrinking, as you know. But you now have pediatric coverage. And if I'm buying insurance, you know what the ACA did? Every insurance policy has to have all 10 of these. You know what that's like? That's like my telling you that every single car in Peoria should have the same tires. Same size tires. Every vehicle has the same size tires. Oh, hold it. They're round. They get you from A to B. One size tire. That's all we're going to produce. That's what this is saying. Now, you know the good news of this? I'm in the self-funded business. I don't allocate a premium. Guess what my actuarial use rate is going to be on that PEDS piece? 0. I've been self-funding HFN's benefits since 1999. Didn't have 50 employees sometimes. I had phantom employees. Employee 1, 2, and 8. loss ratio was awesome. Those are really healthy people. Okay? But it was the only way I could buy stop-loss insurance on a spec basis. The point is, if you're self-insured, this doesn't impact you because it's based on utilization. If you're buying insurance, it impacts you. And then there's no way of knowing what's going on with Dave. None. You have no information. That's why Pekin started their TPA side of their business. That's why they provide you information so you know. You can't manage if you don't have information. All right? So now let's evolve. And medicine is evolving. So you're saying, well, hold on. How am I going to be able to deliver medicine in the future? The old days was intuitive. You'd go in and see the doc. You'd say, okay, and he'd give you a shot or to take care of you. And how many of you had kids, right? You ever take the kids to the pediatrics? Did you ever see the pediatrician? Huh? Once in a while. Most of the time you saw the nurse, kids got an earache, right? Okay, here's your Z-Pack or whatever they gave you, off you'd go. And what's going on is we're moving from precision medicine, from intuitive medicine to precision medicine. You know, in your workers' comp side, it's all precision medicine. It's all protocol compliant. How did we get into precision medicine? Tommy Thompson, under Bush 2, 10 years ago said, I'm never going to get medical malpractice. So the way to do it is to have standards for care by episodes of care, and if I follow those standards of care, I'm indemnified. That's how we got the protocols. Today, that's how we're operating. All right? You don't send your employees to a certified occupational health site that doesn't follow ACOM guidelines or ODG guidelines, occupational disease guidelines. You don't send them to the doc on the corner. Now, in addition to that, how we're going to receive care of our primary care offices are going to change. You're going to see disease in one bucket, wellness in another bucket, and then when I come in and I see you and I say, you know, I really do feel pretty lousy. And you say to me, yeah, you look pretty lousy too. But the reality is, all right, so what's going to happen? He's going to go to the diagnostic side. He's going back to the art side. The primary care doc's going back to the art side of the business. And all of the rest of this is going to become literally intuitive care. Walmart is designing clinics in every single store in the United States. CVS just put a new clinic in Peoria. CVS's clinic will not build a clinic that does, pharmacy that doesn't have a clinic. Space for the clinic and parking for that clinic. Why? It's all fact that we're into intuitive protocol medicine. Is that bad? No. Okay? As long as it's electronically connected to a medical home environment. As long as they know wherever I go, what's going on with Dave Kolb. So they all know about my psychiatric meds. Got it? They need to know. And then you need to have profiles. You know what it costs you to get a profile on yourself? About $6 a year. If I have 2 years of your history, of your medical data, claims data, and 2 years of your pharmacy data, I can predict your healthcare costs at a 95% confidence level. All right? I use this for HFN. You know what my reinsurance rates went up this year? 1.2%. Why? Don't talk to me about trend. Okay? I'm 95% confident. The only thing I don't know is when she leaves here today, she's going to be so irritated with Bill, right? She's going to have an accident out here in the corner. That's what I don't know. And that's why it's not 100%. So the reality is I can also get a profile of my company. So what's going on within my company? Right? But if I have a profile on Dave, why can't I share it with my primary care doc? And tie that information back into these are the protocols you need to follow because of what's going on with Dave. This information is all available to us today, except we're sitting here, we're in farm country, with all these silos. And we have no feeder system that goes between the silos. So what we're trying to build is the feeder system and put it in place to make this information work. Because we all know 83% of our healthcare costs, right, are sitting here from chronic diseases. And most people are poly, which means you got more than one. Probably all got some kind of chronic diseases. We're not going to talk about Bill because someplace between 45 and 50% of the population today has a chronic disease that is being treated. And so from that perspective, for every dollar you pay out in health care, way back to where we started, that 9% of payroll, along with everything else, you're going to have $4 of impact in your organization. God knows in this state, we need to do everything we can to be as productive as possible, to be as competitive in the world as humanly capable. We have a huge hole to dig out of. Hopefully everybody voted yesterday. That's the way we, in essence, have impact. And when I did a presentation for the chamber last week, I darn near threw up when I heard that over 90% of the incumbents that sit in Springfield are reelected. And 2/3 of those run unopposed. Okay? It's the opportunity we have. And it's not an opportunity, it's our obligation as a part of this country. It's our chance to have some voice. But you got $1 in health care. You got $4 of impact on your company. So if you're sitting in HR, or if you're a COO or CFO, you got to look up, not down. Okay? We have to manage this stuff. Because 7%, there were 60 people in this room, right? 4 people in this room started in January pretty healthy and have now transitioned to being not so healthy. With all the snow we've had and the weather we've had, all right? Every time Bill holds one of these, it's a storm. This year, thank God, it was blowing pretty good coming down here today, but the reality is at least it wasn't snowing, okay? So you did well. But somebody in this room needs to leave this room when we're done and go see their primary care doc. And that may be you're sitting here and you're feeling really good, right? And Steve says, well, I know my cholesterol, if it's under 200, I'm okay. And I feel really good today, so it must be under 200. And he's sitting here at 435. He's a ticking time bomb. And he doesn't know it. All right? So we need to do something about that. Now, so what's happening is we're going to now start to put stuff into a more personal vein. All right? And as we put it into a more personal vein, literally plans are transitioning from defined benefits to defined contribution. Because what's a defined benefit? All right? What's that defined benefit? 77%, it said in this little book that I read that came out in March, of the people have a defined benefit plan in the United States. In the next 5 years, they think that's going to go to defined contribution. Because a defined benefit is, again, like saying one size tire fits every car. And now the federal government said, by the way, if you have a defined benefit, here's the essential benefits. You got to have them all. And if you don't think we're all going to get hit with penalties under the Cadillac plan, you're wrong. If you have essential benefits like that, I did a bunch of docs. My brothers are docs, and they talk to me once in a while. The reality is that we were visiting with these docs in a seminar like this, and I had put the essential benefits up, and I said, what's missing? If you were to add a benefit you really want, what's missing? I didn't get any answers. That's a comprehensive Cadillac plan, okay? And that's the way it was designed. But look at the transition that we think is going to happen. Why? Because it puts you more in control under defined, right? Not under defined benefit, but under defined contribution. Here's your money. This is how we're going to spend it. And maybe it's on a debit card. And so we have fewer restrictions in terms of that process. And the reality is we're going to hopefully get the member itself, you and I, to be more informed decision makers. That's our goal in terms of where we're going. And if we now take that defined contribution and take it into a medical home structure. You know what a medical home structure is? Right? You know what a comprehensive clinic is? Where you got a primary care doc and you got specialty docs around it and they work with a common EMR, electronic medical record. So whoever you're seeing, they know. They call your profile up. Okay? And there it is. They know what your pharmacological history is. They know it's time for certain procedures that you need to have done. And everybody's looking at the same information and contributing it to it. Okay? When you have a medical home environment, the most recent study I saw came out of Michigan. It said, look, it's 3 to 5% in terms of improvement of health, 25% in terms of dollars, and 70% of the family practitioners and internists in this country are working on creating medical home environments. So we experimented with one in Peoria. You know where that city is? A little west of here. Okay? So we experimented with one. We said, gee, we took 600 lives. We picked the institution that has the better outcomes. I'm not going to tell you which one it is. Okay? But it doesn't start with O. And the reality is, we moved market share for 600 people by just telling them they had to pick a primary care doc and see that primary care doc for a profile from 25% of the care to 82% in the first year of implementation. Then look what happened to the ER visits. Same thing, but we knocked off a chunk of them. So then we took 1,000 employees up in Rockford. That's a little city north of here. So we had 1,000 employees in Rockford. And there we had 3 options. We picked the one that was better known, that had the higher market share. And we said, they're already doing 60% of the care. Can we, in essence, raise it? We got it to 90. But we knocked off a quarter of the ER visits by getting people to do primary care visits. These people were making minimum wage. No, I shouldn't say that. They were making $12 to $15 an hour. $12 to $15 an hour. We went to the provider and said, tell you what, I need 4 points to offset the deductible and the copay. You don't, because you lose 34 cents out of every dollar you try to collect. Cost you that much to collect it. You ain't going to collect zip. Don't need to. All right? That number next year will climb again. So, if you, in essence, take a medical home, you know what? Now I'm back to that medical record. And if you think about the fact that 7% of your admissions are from drug incompatibilities, that's not street drugs. Okay? That means you're going to the doc in the box because you don't feel well and there's no coordination between your primary care setting and the doc in the box. Let me tell you where this is huge. We probably do 50% of the workers' comp in this state. We do the state of Illinois, and if you want me to tell you about stories, I will. And he's recording, so I won't. All right? So the whole thing here from that perspective is that 7% of the admissions in this country are from drug incompatibilities, right? And HIPAA is the worst thing that's ever happened to this country. It's given everybody an excuse to do nothing. Okay? And they still say, hey, Dan, come in here. I'm sorry, I forgot. I'm old, remember? So, Dan, it's your turn to see the psychiatrist, right? They still do that. And you know what? We'll die and they'll still be doing that. Hadn't changed that at all. So the reality, second, 7% of the mission. If we in the Accountable Care Act had said we need to, in essence, have electronic connectivity, we could have taken 7% of the healthcare costs out of the system, and who'd have cared? You want to be admitted because one drug is incompatible with another? I don't think anybody'd volunteer. Who'd care? So, now, let me tell you about going to a fiduciary pharmacist. And Caremark and some of these people are not happy with what we're doing. You take a fiduciary pharmacy, focuses in on spread. 75, 80% of the drugs that are dispensed, over 70 anyway, in this country are generics today. Okay? The spread is the difference between what Walgreens gets paid and what you pay to have Walgreens paid. Nobody is taking more money out of the system today. You're really recording this, aren't you? Than the pharmacy benefit managers. Nobody. Here's an example. All right? This is me. I'm on generic Lipitor. It's hard to believe I take any drugs besides psychiatric, I know. But I'm on generic Lipitor, and this thing is so small I have to cut it in half. I only take 5 milligrams. I don't know why, because my cholesterol is 140, but they say it's like Roto-Rooter, keep taking it. Okay. So the reality, that's what my brothers tell me. You know, it's good, Dave. You like French fries, and that's, you know, so take a little Roto-Rooter. Anyway, so the Walgreens price, same Walgreens, $161.99. Under the old PBM service that I'd put in place, $150 is what HFN paid. I paid 25% of it, about $38. I went to pick it up in January to make sure the system was working. And the guy said, that'll be $8. I said, what? I said, what'd the drug cost? $36. This can't be right. But I picked it up, took both slips, right? The one from October, one from January, sent it off to Pharmavale and said, hey, this can't be right. Came back and said it's right. What that singular drug saved my company, that the former PBM was keeping, Walgreens was getting paid the same, was $460. One drug. Okay? Now, you looking at that? Paying any attention to it? A lot of people with their hands out in that business. Okay? A lot of people. And then e-medications. Under the e-medication side, what I'm trying to do is say, okay, what's your profile? Can I check it against where you're at? This whole e-medication prescribing, are you out of compliance? And then, am I monitoring you? E-medication structures, and Medicare is forcing it. They're penalizing the docs big time if they don't prescribe electronically. They're trying to get to some of this. But at the same time, they aren't affecting the PBM side of the business. You have the ability to do that. Grace, who we mentioned earlier, picked up a prescription the other day, and she said to me, this was yesterday, we were doing a seminar together, and she happens to be off seeing at a doctor visit today. We were doing a seminar yesterday for the Small Business Advisory Council of the state of Illinois. Okay? Interesting group of people, because nobody in the room's got more than 25 employees. So the reality is that she said, I went to pick up a script the other day, right? Pulled out my credit card, and they said, that'll be 83 cents. And she said, when I picked it up the last time, I used my credit card. I don't remember what it was, but I used my credit card. Anyway, e-prescribing is the most significant opportunity. And getting your people into a medical home is where you've got to drive them all. Narrow networks are here. Okay? I gave you a little sheet. We went to Peoria and negotiated with OCF and Methodist and said, you know what? We're going to allow by beneficiary the network. That's what we do. So if Dan wants to use OSF, right, and you want to use Methodist, and he wants to use Peak, fine. That's fine. You could be from the same family, God forbid, right? You could be from the same family, and the reality is you each got cards that are appropriate. and we can track it and pay it correctly. And our friends over here can do that. Now, you got to take this over to workers' comp. So if you're on the group health side and you're in a medical home, you need to have a certified occupational health site for your workers' comp. What percent of your premium in workers' comp is paying Dave Kolb to sit home and watch 1-800-SUE-ME? What percent? Does anybody know? In the state of Illinois? That's a little, 50 is really in the state of Illinois. But 60% of all the cases of injuries in the state of Illinois are backs. So you're right about that. 50% of that premium that you're paying in workers' comp is paying me to sit at home. How many of you have light duty? How many of you have paper clips? How many of you have paper clips at work? Okay? When you go back to work, you buy 2 boxes of paper clips, big boxes. One, the big paper clip, and one, the little paper clip. You pour them together, you put them in a bigger box, you now have light duty. Okay? You now have light duty. And you bring Steve back, you put him on the table, you pour it out, and you say, hey, Steve, I know you only got one arm right now. Pick up those paper clips and sort them. And when he's done, right in front of him, push him back in the box, shake the box up, put it back on the table, and say, okay, you got 3 more hours before you're going home. Steve will feel better very quickly. Okay? Because if you're using a certified occupational health site, all right, when you go into that site, they're going to do more. So if you have a foreign body in the eye, they're going to flush it, they're going to stain it, they're going to send you back to work unless you need to go to the ophthalmologist. You go to Dr. Goodshoes, Dr. Goodshoes will send you off to the ophthalmologist and say, well, it's Wednesday, take the rest of the week off. Okay? He doesn't have the right in an occupational health system to do that. He has to go back to work. The work sends you home unless it's medically indicated. So you need to control that side because it's 50 cents on a buck. Remember we're talking about productivity and absenteeism and presenteeism? That's where the whole thing starts. Okay, now, under 1698, I'm just going to touch on it for a minute. You now have the right to direct your employees, all right? And in addition to that, in order for us to be licensed, we were one of the first 3 licensed in the state as a preferred provider program. We had to cover every single state, every single county in this state with a primary care doc location within 15 minutes, 15 miles, 30 minutes of the domicile location of not the employer, of the beneficiary's home. So those payroll records, Jennifer, right? We need those payroll addresses because we have to verify to the state of Illinois where every single employee lives before you can implement the PPP. Now, from that standpoint, if you have less than 3 injuries per 100 full-time workers, then you want to do it on a workers' comp direct basis where you have everybody going to a location. If you have more than 3 injuries per 100, then deploy the PPP. Because the PPP basically says, look, the employee now has the burden of proof. Then they went in and did a cost reduction. I'm going to skip through that, Bill. And the reality is, I got to tell you about this. Can I tell you about this? You know, when they did this fee schedule, they took the docs and they put them into 4 regions. Then our friendly hospital association, and I am a hospital administrator, I can say this got involved, and they decided to create 14 regions. And last fall, I was doing a seminar down here, which is a long ways. And because there's a sign that points to Memphis down there. And I said, who's in Alexander County? What's going on in Alexander County? And some little lady in the back, God love her, raised her hand and said, we're building a hospital. And then she disappeared because I wanted to find out who we were. All right? Who's we? All right? We're building a hospital down here. But anyway, you have to have the utilization review is a misnomer. None of you should be using UR today. Come on. UR died 10 years ago. It's case management today. How many pre-certifications are we really involved in? Okay? Does it make you feel good? No, it's a way for somebody to make $1.50 employee per month. The reality is that we want case management. But under the case management structure of the state of Illinois now, the commission, whoever's hearing that case, has to take into consideration the UR recommendation. In addition, they have to take into consideration the AMA guidelines. This was probably the most significant thing that was put in place. So from that standpoint, if you use the right primary care structure, you're in essence picking up that case management and you're picking up the opportunity for those guidelines. Now, so employers you can direct. Once you direct it into the system, the providers have to stay within network. And if the employee goes outside of the network, it's their responsibility. But you can opt out twice. So I can give you a piece of scratch paper and says, I don't want to go see this guy. Okay? That's fine. You still own that bill. But then you say, I don't really like him anymore. I want to go with something I can't. Okay? You have to submit a letter to the commission showing why his care is ineffective. Okay? And they have 5 days to respond. We're still waiting to see one of those letters, because that'll be fun to watch. Because there'll be no way they'll get back 5 days. But the reality, that's what it is. But they have the right to opt out. But if they opt out, you have a right to do independent medical review, and if they do anything, you can pull them back into the system. So the PPP does have some teeth in it, and there's packages that you got to put together. Now, the state took the signature off of this. So we figured out a way around that. What we do is put this in a packet, and we have the employees sign that they received the packet. Got that? That was Grace. She did that. And then there's 12 policies and procedures. So it says, look, if you don't have a neurologist and you're down around Mount Vernon or someplace down south, how are you going to provide coverage for that? We have samples of all 12 that you need to put in place. And then you got to have posters to get people directed. So what are we trying to do here? We're trying to focus people into the right areas of care. What time was I supposed to be done? 12:45?
You told them 2 o'clock, nobody walked out.
It was 12:45, right?
No, it was supposed to be done at noon.
Well, I'm on a 12:45 run here. Anyway, so, and
12:45 pace. Well, it's only 11:30, so I mean, you've got a while.
I got a while. Okay. So what we're really doing here is think about the fact that we're trying to avoid ERs. And I want you to think about for a minute where we are in terms of that. Think about that medical home slide I showed you, right? If you remember, one of those had a 23% reduction in an ER because we were able to move those people to going to visit a primary care doc instead. You know, if you're trying to keep your people healthy, if you're trying to, in essence, encourage them to receive care in the right location, the reality is most people will accept that offer if, in essence, you put the offer in front of them. So don't hesitate by saying, boy, this sounds like a lot of work. Because the other thing I'm trying to get you to do is think bigger. All right? If you're really responsible for productivity in some way within your organization, if you're a COO, this has got to be music to your ears. If you're a benefits manager, you may be saying, this sounds like a lot of work. Okay? But the return on this effort is significant. And you know, the really neat thing about Unland, I mean, as a company in addition to Bill, right? They get it. They get it. It's not a bunch of silos. It's a matter of how, in essence, UE, in essence, package these kinds of service. So if you're in the workers' compensation side, and I'm going to talk about something in a minute, one of the things you want to do is record. If you have people, in essence, that are going out on workers' comp, you should record the initial conversation with them when they inform you. Never will you have a more honest conversation than that relative to that incident. Never. Right? So you want it recorded. Second thing is you want to send them to the appropriate medical provider that understands what they're doing and is following guidelines. Third is you want to understand, all right, from the standpoint of your maximum medical improvement and, you know, what's going on with that particular case. The fourth thing you want to do, keep those people close. Any of you got workers' comp people that have been off work for more than a week? Well, you're blessed. Count your blessing. If you do, never do you go by a week go by that you don't talk to them. Never. And in fact, you may want to drive over and see them. But never a week goes by that you don't talk to those people. And the minute they return to work, resolve the issue. Those are very solid pieces of advice from people much more knowledgeable than I'll ever be. And so if we think about presenteeism and how it impacts health and productivity, people are focused on absent management. So why isn't Dave at work? And if we think about that, how many of you do FMLA? What percent do you think in this country FMLA is done wrong? 2/3. How often do you do FMLA? Let me see. Where's the book? What's the procedure? Oh, my God, why are they doing this to us? I guess she wants off, right? I got to figure this out. No wonder it's done wrong. You don't do it very often, right? So you have to figure out what that opportunity is. And now, short and long-term disability. How many of you manage short-term disability pretty effectively? Steve's off. Hope he comes back soon. Okay? Wonder what he's doing. It is opening day of fishing. Okay? The reality is, if it's an unscheduled absence, we need to be tracking it. I can tell you that when it's not a room full of women, the conversation you get in a short-term disability is everybody who, in essence, is going to have a child prefers 6 months off versus 3 months. And there aren't many physicians that won't agree with that. So is it medically appropriate? And who's paying for it? And boy, that's a touchy one to get in and start to manage around, particularly from the inside. So the reality is short-term disability isn't managed very effectively either. And then you bring workers' comp in here, and what did we just say the one thing you want to do? When somebody says I got a workers' comp injury, I want to record it. So how are you going to go about doing that? So we created a service through Go Self-Insured that basically said anybody who's absent that isn't scheduled as vacation, this is the number you call. And when you call up that number, right, you get the same person. You're going to say, Steve, I'm sorry you're sick, but how's your ankle that you sprained a couple weeks ago? And Steve says, oh, you know about that. You remember that. So the reality is that we think that you should have a singular source for reporting all unexcused absences, unplanned absences, unscheduled absences. A single source in your organizations, whether you're using an outside third party or inside your company. For the 30 years I've been dealing in this business, the thing that has disappointed me the most is I go through the front door right? And I visit with the people about group health. Then I walk to the back of the building, and sometimes that's a reverse, and I visit with the CFO about workers' comp. And if you bring the two of them into the room, it's oil and water. And isn't this one company? That day's done. It's over. Get over it. We got to move on. And this is one of the vehicles we can use for doing that. Okay? And in terms of that process, you realize that half of the people in this country have wellness data. Darn near 100% of them, 90% of them don't use it. And you're gathering information. You have information that you're gathering that you're just siloing. You're recording. You're filing. You're not using. Information for information's sake isn't very useful. And in our companies, let me tell you, we spend a lot of time gathering information just to make us feel good. That isn't very functional. And what we're trying to do here is functionalize some of that information and make it so it's workable. And that's why you ought to have a dashboard. You know what that dashboard was built for? McDonald's. So in our visit with McDonald's, which was kind of, you know, you kind of look around saying, what are we doing here? You know? We say, well, hold on. Can we take and look at your incidents by state, by type, by state? And he said, no. I said, oh. Well, can we do it by kind of store you have, whether it's franchise or non-franchise? I said, no. You mean you guys can do that? We said, you have to build a dashboard that can facilitate that. And every piece of information is different by type of industry, by situation. So this dashboard opportunities for us are significant. You know, my friend Scott came down with me today. Scott Diamond. How's that for a name, huh? Scott Diamond. Anyway, so he came down to me. He runs a company that's, I don't know, $80 million. I don't know, he's got, how many states you in? 17. He's basically in the, if you need employee replacement business, he's got them. And they're real heavy in the IT world. And so what we've been working with Scott to say is, you know what? Maybe there's an alternative way of providing benefits. Because I'm truly a believer that those companies that have less than 50 employees, and certainly those that have less than 25, given the regulatory environment of our nation at this point, it is darn near impossible to manage all of these benefits. That's why 2/3 of FMLA is done wrong. That's why STD is ignored. Okay? The reality is, we said, what if we, in essence, provided that employee a home for all of their benefits? And then out of that home, when they work for you, you pay them $20 an hour to do the job, and you pay $5 an hour for all of the benefits, including workers' comp and all of the benefits in terms of that structure. You mentioned ADP, okay? ADP has evolved out of the PEO business. I don't know if they're driving you nuts in the marketplace down here, but they're pretty aggressive. I didn't know it was 1 out of 6. But the reality is, I did listen. So the reality of all that is that if you think about your employees and your structure, all of us are going to need to migrate to what works so that we can continue to develop and be entrepreneurs in this country. And the biggest thing that will keep entrepreneurship under the table is the encumberment of all of the rules and regulations that, in essence, Larry ad nauseum was talking about this morning. God love him for liking that stuff. I mean, we need guys like Larry. All right? I mean, we do. Thank God we have somebody to call. I mean, Bill and I would be asleep by the time we got 10% into that. Right? So thank God he's out there to help us. But this is what he's working on. And so say, what's the next generation that this service provides? Because it is going to be generational. And the only thing I regret, being as old as I am, is that I wished I could work another 15, 20 years, because I think the opportunities in this country are huge. Right? But I don't know if I'll make it to 100. But the reality is that I think the opportunities are significant, but you have to think about differently and raise your eyebrows and raise your thought process to say, you know what, because the essential benefits, okay, the essential benefit requirement, you got to have these 10, and the stop loss arrangements, which says I got to provide, right, the ratio, I got to provide 80-85% of the dollars I take in a premium, have to go out and care. Insurance companies are done. Wise Peak, in essence, developed the TPA structure. They have no flexibility. Zero. And can they make a living on 15%? Thank God they're a mutual company. Because the guys in New York would be going nuts if they were a stock company. So the reality is that there isn't a whole lot of opportunity there. And we now have workers' comp carriers. We now have workers' comp in the state so you can direct. So we can have medical home on the group side, and we can have certified occupational structure on the other side, and we can have coordination between the two in terms of an EMR, electronic medical record. And then, because of the ACA, we finally got reinsurers. I mean, 2 weeks from now, I get to go to Caymans. I mean, it's tough, right? I'm going to the Caymans to do a seminar for Berkeley's MCAT. And because I'm going to talk about this, you know what they did? They stuck it on the program twice. They said everybody has to listen to it. That might be penance, right? But the reality is that we're self-funding people down to 10 employees easily. That's not we can do a spec. The insurance commissioner said as long as the spec is above 20,000, because below 20,000 it's insurance. Okay? So if you have a spec of 25,000 where you're assuming some risk on the front end, and remember 80% of the people never get to their deductible, and only 2% of the people ever hit their spec. In any given year, no guts, no glory. All right? You got to go for it. And then, you know, what do you want to do on a group health side? Here's some direction. Okay? Here's some direction. Easy things to do. You require every one of your employees to have a primary care doc. Okay? Every one of your employees has to have a primary care doc. You want to know who it is? And the penalty? I'm going to throw you off the health plan. Can I do that? Nope. But can I threaten it? Sure. Okay? Then you have to have a health assessment. Okay? Now, a health assessment, for God's sakes, is not the paper one. Steve knows that, again, back to his cholesterol. Okay? He knows over 200. He's feeling pretty good. I must be under 200. There has to be a biometric testing. Has to be. Now, in my shop, 6 or 7 years now, the employee and the significant other / spouse have to have the biometric test in June, or within 60 days of June, or you're off our health plan. I've had 100% compliance for 7 years. And you know what I tell them? You know why I'm doing that, Steve? I like you. And we want you here. You're an asset. You're not a liability. You're on the balance sheet. You're not on the income statement. Okay? You're an asset. We want you to be part of this company. And we want you well. And I need you here productive. 4% of your workforce is an undiagnosed diabetic. How many employees you got? 27. Okay? So after you go back after lunch today, all right, you walk around, you look for the 3 people that are like this. Okay? Now, I hope in your shop that those 3 people aren't driving forklifts. Or yesterday, I'll give you the best example. We talk about DOT physicals. Anybody do DOT physicals in your Department of Transportation physicals? DOT physicals for people driving around. And there is a place on the south side of Chicago, we call it the back of the yards, which you don't want to go to at night. And the reality is that they haul barrels, they refurbish barrels. So figure a 53-foot truck full of 50-gallon barrels. And we're there working with the CFO and the risk manager. And we say, no, this is the COP site we're going to register you in, and you do your DO2 physicals through that. And she said, I don't like that site. I said, why? She said, they make those people come back. And sometimes they won't let them drive. And I need them driving. And the CFO's eyes got big. And I said, let me understand what you just said. This guy's getting into a truck full of 50-gallon barrels, 53 feet long, right? Yeah. And you're going to have him drive through Chicago in that truck after he probably has not passed his DOT physical. Yeah, I need him working. So the CFO looks at me and Grace, and he says, I heard enough. Okay, move on. So the reality is, look, I got to make sure that I want everybody in, and I got to do biometric testing so you can find that 4%. Let me go back to that. You know what a non-diagnosed diabetic has? 8.3 sick days, more than a diagnosed diabetic. That's not the problem. Steve shows up for work 5 days a week, but because he likes to eat the stuff that was back here, not the grapes, but that stuff with white stuff on it, you know, the reality is that he only produces 4.5. You lose a half a day of production out of him. Where'd we start this? Right? It's all about productivity. It's all about productivity in terms of where we're trying to go. Now, so now under Larry, see this right here? You can take 30% of your premium or your contribution on a monthly basis and turn it into an incentive. How many people have kids? Don't reward them, penalize them. You always thank your kids for, you know, oh, that's too bad. Let me fix it. Okay? These are penalties. You don't have the health assessment at HFN, you're off the plan. You want to be back on our plan? Go get your health assessment. Why? Because we like you. And then you know what? We follow up. I don't follow up. We have a third party that follows up. Anybody with a hemoglobin A1C of 5.6 or greater, we're on. We're on them. Okay? Saying, look, I don't want you to get to 6. We don't need you at 6. Then you go over to the workers' comp, make sure you got a designated site. So on the group health side, you're going to make sure they got a primary care doc, and you're going to do a health assessment, and you're going to put incentives in place to make sure that happens, which are penalties. On the workers' comp side, everybody has to have light duty. I don't want to come back and see you in this room again without you saying you didn't find 2 sizes of paper clips. Everybody has to have light duty. And simultaneously with that, everybody's doing pre-employment physicals, and for God's sakes, if you have an industry injury, you're doing drug testing. You should be doing random, but the reality is, at least at the point of incidence, you're doing drug testing. We'll be happy to align you with an appropriate site. All you got to do is ask. We are doing someplace around 400 employee relationship establishments per month right now. We're probably doing half of the business in workers' comp in this state. And we took over the state of Illinois, as I told you, but because of the recording, I can't tell you any more about it. Okay? Then what I want you to do is to think about in your shop or through online, that we in essence get to a single point of reporting for FMLA, short-term disability, workers' comp, any unscheduled absence, single point in your shop. No longer call the supervisor, you're calling here. Right? And you're recording it to that extent. And then think about your pharmacy. So maybe we can get rid of this drug incompatibility. And you should have a fiduciary pharmacist on your group health side, period. That's a no-brainer. And make sure that wherever we're doing medical home, okay, and we use Methodist big time, the reality is those medical homes are protocol compliant. And you want to know what the protocols are, right? And to make sure they got it. We signed 2 contracts. Contract I gave you in front of you is for rates. The second contract we signed with them, performance. You agree to perform in this manner. Isn't that what it's all about? Okay? That's what it's all about. Why? Because you got to take control. You got to take control. And then if you're a really small company, and you think about something that, you know, what he calls is individually directed benefit organization. Next PEO of the world. What are those structures that are going to come? And how does it help me? So I, in essence, can drive my people to a healthier environment, and simultaneously with that, how do I in turn talk about making sure that my company is profitable? All right? Well, I'm a believer, even though it's 5 to 12 and I still got a couple more minutes, right? I am truly a believer that self-funding in this country is here to stay. On the ACA side, okay, Obamacare side, it's the way of saying if I have to live with these 10 benefits, and Dave, you don't need PEDS and OB, I don't really care. I'm going to offer you PEDS and OB and you aren't going to use it. But if I buy it as insurance, that silly actuary is going to charge you. Okay? And it's going to be in your premium, and I can't get it out. So I think insurance is on the backside of its life cycle. You're going to see, I'll tell you something about the ACA they didn't talk about. If you're 138%, you ought to be on Medicaid. If you're going from 138 to 250%, that's called, those people are getting the best slice of the pie, and they ought to buy silver the plan because they get bronze coverage. They get platinum coverage, excuse me. They get the best. Why? In that range, they get a deductible for the premium, they get a deductible for the copay, they get a deductible for the deductible. They get a percentage off the deductible. So the government is paying part of the premium, they're paying part of the deductible, they're paying part of the copay. The poor guy that's really getting taken to the cleaners is that individual working his butts off. Now I'm 260% of Medicare. I get some contribution toward my premium, and now I'm sitting out here with a $200 to $6,300 deductible, and there's no way in God's green acres I can afford that. This has got to change. And that's why I said I hope you voted, because we need people, and I beat up Peter Roskam big time, right, who's the Republican rep, saying, look, stop trying to kill it and fix it. Fix it. We need to take care of these people, then let's take care of them. And for God's sakes, get away from everybody else. Leave half the world alone, will you? And let us fix that. A few months ago, I met with Huckabee, and I said, you know what? I think you're a real man to start with. Thank you. Although, you know the guy, I really like Jeb Bush. I've met with him, too. Anyway, and you know what Jeb Bush talked about? His mother. And why that family is so significant. And you know the other thing he told us about? I'll tell you this story because it's really kind of very good. He said, you know, the war in Iraq tore George apart. And you know what he did when he traveled? And he said, you'll never read about this. You never heard about it in the news. They cleared the news people out. He said, whatever city he went to, he went personally and met with at least one family of somebody who had lost a soldier. And he said, I've been at those, I've cried at those. And he said, you know why he did that? Because we had one heck of a mother. And we may have had money, but let me tell you, we were principled. And he said he still does that today. He goes and thanks those people for the sacrifice that they made. All right? But what I told Huckabee is, look, if you run and you want to figure out how to do this, we can fix this. This is not that complicated. You got the outline here. This is not that complicated. But you know the way that's going to happen? Never happens from the top down. Happens from the bottom up. It happens from the bottom up. Don't look for him to fix it. He can help you fix it. You got to fix it. No guts, no glory. It's your company. You got to do it. And it's not rocket science. All right? And it's not expensive. I mean, those reports I was showing you was MedAI. You know what MedAI charges me? Right? 50 cents per employee per month. Come on. Right? I just need to kick my PBM in the butt a little bit, and I got plenty of money to do that. So thank you for your time. God bless you for what you're doing, Bill. Thanks for the invite.